This video is about long-term cures with biological response modifiers, cures of lung cancer. This is the Mississippi BRM experience. And I'm R. Arnold Smith, MD. And this is a sequel to the other video of John Reese, also found on this channel. Here I present evidence that John's extended survival from extensive non-small cell lung cancer, or an SCLC, with biological response modifier, or BRM therapy, was not unique. More cases of extended survival are presented here. In search of the literature, I have been unable to find another individual with over 15 years survival from extensive non-small cell lung cancer. John is just plain old unique, as far as I can tell. Carefully examine Exhibit 1 and carefully determine if you are interested. Now, Exhibit 1 is a page from the JAMA, the Journal of the American Medical Association, which is the most prestigious journal that all physicians get if they're members of the American Medical Association. And this article states that even though there have been many clinical trials of chemotherapy for lung cancer, none of them have proven any benefit. So I'm going to read this little section. It says, for non-small cell lung cancer, despite the persistent lack of proof of efficacy of any active treatment, and this goes on to more stuff. So there's just lack of efficacy. Just it doesn't work. It's basically fraught with failure. And so NSCLC treatment with chemotherapy is really an expensive, unproven insult to health and quality of life, associated with unimproved or worsened survival. Cytotoxic chemotherapy is not worthy of the name, and we shall call it chemo. The morbid side effects of chemo are easily observed. Hair loss, muscular weakness, diarrhea, pneumonia, septicemia, psychological depression, and general systemic collapse are typical side effects. And these side effects result in decreased length and quality of residual life. Chemo in the 1970s and 1980s and later was a morbid, unproven insult to beneficence. Evidence is referred to here that benefit from cytotoxic chemotherapy is not just unproven, but disproven. So in my opinion, the current vogue of immune checkpoint inhibition, or ICI pharmacology, is conceptually flawed and will eventually lose credibility as a cancer treatment. ICI unleashes autoimmune disease and free radical-induced accelerated aging. The hospital pharmacological physician establishment appears to be barking up the wrong tree again. UMMC data is a product of the University of Mississippi Tumor Registry. MBMC data is the product of the Mississippi Baptist Medical Center Tumor Registry. SEER is the product of the Surveillance, Epidemiology, and End Results Registry of the National Cancer Institute. It is well proven that an initial NSCLC shrinkage or regressive effect resulting from chemotherapy often occurs, but that this regression does not correlate with either increased length or quality of life. Accordingly, we will appropriately call cytotoxic drugs chemo, and not by the deceptive misnomer euphemism chemotherapy. We may presume that the telomere shortening consequence of cytotoxic chemotherapy becomes determinant in markedly decreasing longevity and survival after chemo. This direct genomic insult completely negates any anticipated long-term survival benefit commonly anticipated after common NSCLC regression induced by chemo. This website also demonstrates biological response modifier induced superior survival and probable cure in extensive or unresectable NSCLC. The probability the method can be improved or extended to other carcinoma diagnoses is high. During my 40 years of practicing radiation oncology in central Mississippi, I treated more lung cancer patients than any other physician in the state. This was because for several years I was the only fully trained radiotherapy practitioner in the state. For several initial years, I had almost a monopoly on private practice patient accession for contemporary radiation therapy. I was an honor graduate from college and medical school. I was well trained and board certified. Patients often arrive for treatment from up to 100 miles away. In addition to providing conventional radiotherapy, I acted as an advisor and provider of biological response modifier medication to several thousands of patients. BRMs are perceived to restore and stimulate innate host cancer defenses, and in contrast to chemo, have little or no toxic side effects. BRM pharmacological intervention was not and is not part of typical or standard radiation oncology practice. BRM therapy is presently a profitless bastard child of cancer care. Hospital administrators are not in the business of extending patient survival through accountability of treatment outcome and treatment optimization. Instead, hospital power protects profitable methods of treatment and physician practices profitable to the hospital. I believe that most patients taking BRMs, as described herein, experience both quality of life, subjective benefits, and survival extending objective benefit from BRMs. Evidence is presented here that BRM produces a statistically improved survival in NSCLC. This video details for the first time the findings of this years-long research in the most commonly irradiated cancer, non-surgical NSCLC. Hundreds of man-hours were required for this BRM investigation. This study benefited from no outside funding. The principal researcher and creator of this video believes the investigation was, quotes, the right thing to do. Several months after starting radiotherapy practice, it became apparent that lung cancer patients were to be by far my largest recognizable treatment population. After the John Reese experience, patients were routinely advised to take cimetidine 300 milligrams 4 times a day, vitamin E 400 IU 3 times a day, and Premarin 1.25 with methyl testosterone 10 milligrams twice a day. They also were advised to take ascorbic acid mixture of Cameron and Pauling. It's important that this preparation of vitamin C be used and not pill form vitamin C. See the John Reese video for more ascorbic acid mixture compounding specifics. Not all my lung cancer patients received BRM, as some of them were refused because their referring physicians did not wish them to take it, and that became determinant. After a few years, I recruited a second radiation oncologist, Morris Trawick Reagan, or MD or MTR, to practice with me. MTR, by agreement, did not practice BRM for his cancer patients. In our combined practice over several years, there were many lung cancer patients who did not receive BRM advice. This communication describes for the first time the superior survival of the BRM-treated patient population. I remain grateful to MTR for his help, and he was a good associate and a good friend. This is a retrospective study. There was no randomization. The dates of the initial pathology reports provided the beginning dates for individual patient accession. Death dates in Mississippi Baptist Medical Center and UMMC tumor registries were obtained from the Mississippi State Board of Health. By far the most valuable and objective assessment of BRM's efficacy was created by combining the survival statistics from the Surveillance, Epidemiology, and End Results Registry of the National Cancer Institute with data from the American College of Surgeons, approved tumor registry at the Mississippi Baptist Medical Center, where I was a hospital-based radiation oncologist. Also quite valuable were survival statistics from the ACS-approved tumor registry at the University of Mississippi Medical Center, or UMMC. Survival data from MBMC and UMMC could be compared with survival data from SEER. MBMC and UMMC were and are physically located in the central Mississippi capital city of Jackson. To help settle controversy, I requested through the MBMC Cancer Committee a 4-year interval retrospective review of non-small cell lung cancer patient survival from MBMC and UMMC as a function of type or types of cancer treatment. The MBMC and UMMC cancer committees agreed with this request. Treatments evaluated were patients receiving 1 BRM and standard radiotherapy with or without chemo, 2 standard radiotherapy alone without BRM, 3 standard radiotherapy with standard cytotoxic chemo, and 3 radiotherapy alone. Patients received only one of these combinations of treatment. Time interval for the Central Mississippi study was 1985 through 1988. That's 4 years. Okay, the first chart that I present here was produced actually by computer graphics at the University of Mississippi Medical Center, but it graphs the University of Medical Center experience with chemotherapy survival in non-small cell lung cancer, the Mississippi Baptist Medical Center experience with chemotherapy and non-small cell lung cancer survival, and the ones treated at MBMC, or Mississippi Baptist Medical Center, with BRMs. And there's just a radical difference which you can see on this chart. The BRM patients are much slower to die, the ones that die, and furthermore, there's a horizontal part of the curve towards the end which looks like the people have quit dying. So these are the patients that I suspect will go out to John Reese type survival. And that flatness of the curve is out at 50 months. So that's 4 years, and it's flat. That's pretty strong evidence. Exhibit 2 is the formal report compiled by Pam Barlow, tumor registrar at UMMC. This report is free from bias of me or MBMC. Note the specific manifestations of extensive disease in the charted data of survivors. That's on the second and third pages. In a 1990 report from the American College of Surgeons, it was established that chemo at Mississippi Baptist Hospital was employed at 150% of the national average rate, or 50% higher than the national rate, Exhibit 3. If chemo were beneficial, one would expect some evidence of improved survival from this arguably superior care. Survival at MBMC was actually worse than SEER, so it certainly didn't show any improvement. Recall that MTR, my associate, did not employ BRM. RAS could only employ BRM if there were no objection from the referring physician. Only BRM was treated patients who were associated with superior survival of RAS patients. Exhibit 4. Now, Exhibit 4 shows curves of my patients with no chemotherapy with BRMs and no BRMs. The ones that did not receive BRMs are 31 patients, and they all just died. The ones receiving the BRMs showed some survivors. The next exhibit, which was SEER distant non-small cell lung cancer, treated by me and by Morris Reagan, or MTR, with no chemotherapy and no BRM. And they just died they just all died. So the only patients that were living were the ones that got the BRMs. The rest of them were dead. So in observed to expected ratios, which is the third page here, the observed survival was 11% in the BRM plus radiation therapy, plus or minus chemotherapy. And with no BRMs, it was only 5 of 283. So that was 1.8%. And the difference in the observed to expected ratio was huge. The survival rate with the no BRMs was essentially what we expected, but the rate with the with BRMs was much greater. It is well to recognize that lung cancer referring physicians were often pulmonologists who had to be wary of offending their referring colleagues. Pulmonologists are typically members of large internal medicine clinics and dare not advise BRMs for fear of alienating conventional colleagues. Convention is a powerful and reactionary competitive pressure in private practice. Comparison of MTR and me, or RAS, was pretty radically different, and that's in this next Exhibit 5. There was clear benefit to the BRM patients, and this benefit did not show up until about the last 11% of patients, and then the curves rapidly diverged, which you can see, and the BRM patients got a lot better at that point. This curve's horizontal, and look at all the vertical hash marks on this curve. So those are patients that are still alive, and they're going to survive. Okay, the ACID test was whether the BRM methodology would compare favorably with SEER data. SEER is huge, and it's very you get fundamental data from SEER. The graph in Exhibit 6 answers this question. BRM was superior to SEER. Non-BRM at MBMC was statistically worse than SEER. That's where all the chemotherapy was going on. Graphic displays of lung cancer survival percentage as a function of time elapsed since diagnosis are highly informative. It was noted after results were charted on Semilog paper that the death rate of lung cancer survivors was remarkably steady in both SEER and Central Mississippi. For several years after diagnosis, this reality is elegantly expressed using Semilog graphing, with time since survival on the horizontal x-axis and percent survival on the vertical y-axis. See Exhibit 7. This exhibit reveals that when the Mississippi Baptist Medical Center and UMMC survival data were pooled, and this combined survival data graphed against survival from the huge SEER registry of the National Cancer Institute, a remarkable coincidence in the survival curves is evidence. The two Central Mississippi and SEER curves are noted to be virtually overlapping, slightly curved lines. Conclusion: the two death rates were predictable and relentless, with no evidence of cures until a terminal plateau on the Central Mississippi curve appears to be attributable to the BRM effect. Lack of a terminal plateau on the SEER data indicates that BRM approach described here was uniquely effective for producing long-term survival. Cures from non-small cell lung cancer will remain elusive until there is a focus on restoring the innate or intrinsic immunity of reproductive adulthood, present ages 15 to 38. Powerful economic vested interest dynamics operates against this philosophy of immune restoration for NSCLC treatment. Cytotoxic chemotherapy alone is worse than worthless. Immune checkpoint inhibitors are capable of only marginal benefit at great economic and quality of life costs. Those darn treatments cost like $7,000 every 6 weeks. Very expensive. Long-term survival with immune checkpoint inhibition will remain elusive as checkpoint obliteration accelerates the aging process. There are several BRM agents readily available which can be used concurrently and which are efficacious in innate immunity restoration. Many of these useful agents, including cimetidine, vitamin E, and ascorbic acid mixture, are unpatentable and available over the counter and do not require prescriptions. The full regimen described herein, including gonadal hormones, requires a participating physician. There will be obstructionism against BRM pharmacology from the pharmacological hospital physician vested interest establishment. An informed NSCLC victim can influence his or her destiny. However, an intense BRM approach is described here is compatible with other contemporary treatments. An interesting article was published about how most oncologists would want to be treated if they had non-small lung cancer. Most of them would refuse it. Most of them wouldn't take it. So it's really reminiscent of the teetotaler bartender. Only sell the stuff, don't drink it. Widespread use of cytotoxic chemo for an NSCLC was one of the greatest medical boondoggles of the 20th century. Patient survival from SEER or MBMC and UMMC tumor registries were initially presented in a tabular form, and this data converted to linear graphics presentation by Bill Buhner of computer graphics at UMMC, who was a very great help. Dr. Henry Hsu of the University of Mississippi Department of Biostatistics calculated p-values and was also a very valuable contributor to the research. Medical oncologists Van Lackey, Claude Stubblefield were extremely helpful and supportive referring physicians who helped make this clinical research possible. I've already mentioned Dr. Morris Reagan and his wonderful help as a friend and colleague.